All right. So today, today's session, this morning session, the first 30 minutes, 30 to 40 minutes, will be about the CHA policies and procedures. I will do this portion, and then the last 45 minutes to an hour, Diane will take over and do the overview of the healthcare system. Again, if any questions come up, feel free to type it into the chat, the questions tab. To gain access of this PowerPoint, you will find it under the handouts tab. So let's begin. All right. So we're going to start with an overview of CSS. So for those that are new and don't know CSS, CSS is 175 years old. It's a large nonprofit, and our mission is to be a leading voice on behalf of the poor and low-income New Yorkers. So essentially, we do this through research, advocacy, litigation, and innovative program models. We lobby in Albany, we write reports and papers, and we do direct service work. And as you can see down here, these are all the different services that we provide and try to tackle. So our approach is like a three-legged stool. We provide, just like I said before, direct health access services, policy analysis from a consumer's lens, advocacy, organizing, and rapid response. So within the Health Initiatives Department that we have at CSS, we have 4 main programs. We have a Navigator Network, which helps individuals and small businesses enroll into health insurance. We have ICANN, the Independent Community Advocacy Network, and we help people solve problems with Medicaid long-term care. We also have CHAMP, which is a community health access to addiction and mental health care project, and that helps people get access to mental health and substance disorder treatment. And then there's CHA, our program, which helps people keep and use their health insurance. So usually, and I'll talk more about the helpline, or when people call the helpline, when clients call the helpline, if there are any of these other programs that can help them, we can direct them to them. But we all work together, all 4 programs, and we're all at CSS. Okay, so how CHA helps consumers. And many of you already know this. We do post-enrollment work, but we also help with enrollment in non-marketplace coverage. We help consumers understand how to use and maximize their coverage, remove barriers to access to medical services and other healthcare services, resolve medical billing issues, prescription drug cost issues, finding inexpensive care if you're uninsured or underinsured. And we track issues to report back to policymakers because the whole goal is to essentially make changes so consumers don't go through these issues over and over again. Great slide. I'm sure many of you reach out to me and have no idea how I look. That's how I feel as well when I reach out to you guys, and I really look forward to meeting you one day. But here are some pictures of individuals that are at CSS who help with CHA. So Elizabeth Benjamin, many of you might know who she is. She oversees the Health Initiatives Department. Juan helps with lobbying efforts. Miriam manages the story collection process, and I'll talk more about that later. Diane, she oversees CHA internally and helps with the network as well, but she helps a lot with the helpline and case handlers here at CSS. Most of you might contact Nakia and I. Nakia manages day-to-day operations for the CHA network, And that includes contracts, budgets, and providing technical assistance. And she'll be back July 6th. And then there's me. And I provide contract support, technical assistance, conduct QA, and try to answer any questions you may have. So yeah, as I said, I look forward to meeting you all in person one day. All right. So what is our role at CSS? So we're the contract administration. What does that mean? We oversee the monthly progress of all the community-based organizations in the CHOT network. So we look at the number of cases per month for the entirety of all the network. We provide quality assurance of services. So we look at the cases, and I guess when COVID's over, we'll once again provide site visits. So we're the main contractor. And then we provide technical assistance, provide the trainings. We write the reports and analyze the data, identify and address systemic issues, and we manage the helpline. Now, more about the helpline. This is the helpline number, and it's staffed by CSS and trained volunteers. And it's open Monday through Friday from 9 a.m. to 4, and of course it's free. And we answer over 10,000 calls every year. And most of the cases that we handle at CSS are commercially insured cases. Okay, but we're not the only ones that provide trainings and technical assistance, and you'll see this week, if you're new, that the Legal Aid Society, Medicare Rights Center, and Empire Justice Center also provide trainings and are great resources for technical assistance. So in the CHOP policies and procedures appendices, there are guidances for referrals and technical assistance for each specialist agency. And they take referrals for complex cases. So, and I'll go over what types of cases they each take. But if you're having trouble with a case, you are totally welcome to reach out to one of the CHA specialist agencies here or CSS. So here's the guidance in general for upstate and Long Island advocates. If you're in upstate or Long Island, you can reach out to Medicare Rights Center for any Medicare-related questions, or Empire Justice Center for all other CHA cases that are not only Medicare-related. For downstate, you can also reach out to Medicare Rights Center for Medicare-related questions, and then Legal Aid Society for all other CHA cases that are not only Medicare-related. And if you're for upstate and downstate, for any questions, you can reach out to CSS. So you have 4 specialist agencies that you can reach out to if you have any case questions. A picture. I'm assuming this is from past years, Albany June intensive 2-day trainings. We'll go back to that, but that's advocates, and some of you might be in this picture. And you all provide services to both individuals and small businesses, which is great. So here's a map of our network. I have to update this because there are some changes, but as you can see, we serve almost every county in New York State. And I think, yes, I think it's every county because I see a flag on every single box. That's great. So if you, let's say you get a client that lives in Essex, but your agency is in Green, we can refer that client to an agency that's in Essex. The whole network can work together to serve all New Yorkers, and that's great. All right. So now to get to the details that are really important. So every agency has a subcontract with CSS to provide CHA services in specific counties. And If you're not aware of what counties your agency serves, you can talk to your CHA coordinators. But the subcontract also specifies what your agency's deliverables and baselines are. And in order to receive payment for each month, each agency must meet the deliverables. So what are these deliverables? The first one is to attend all required monthly meetings and trainings. And this includes the CHA intensive trainings that will be given this week. So, of course, due to the COVID-19 pandemic, everything, that should say 2021 to 2022, will be web-based. And I can keep track of that via GoToWebinar. So I just want to make sure, again, to reiterate, if you are calling in, please email me and let me know so you can receive credit. But I can also see how long people are on, and I know things happen, but yes, just want to alert you all that that's how I keep track for this deliverable. As stated in the CHA policies and procedures, you should not schedule any CHA activities during the required meetings because they only happen once a month. And August we have off, so we only have 11 monthly meetings during the year. And if there's a compelling reason, you must notify Nakia and I in writing before the monthly meeting, and just let us know what's going on. So again, you can find more information on the deliverables on the CHA Policy and Procedures Manual on pages 7 through 9. But this is just one deliverable. The second deliverable is meeting your baselines. And that's essentially the number of contracted cases your agency has. Again, if you're not sure what number of contracted cases you might have, please reach out to me and I'll take a look and I will let you know. Now, of course, things happen, and if your agency anticipates falling behind in a given month, you must submit to CSS a written request to roll over the unmet baselines onto the next month, at least 5 days in advance of the current month's end date. And yes, you just need to notify us immediately. It's much easier for us to figure out a solution if you reach out to us versus us finding out later on. We don't want to reduce payment, but at the end of the contract period, if no one has reached out to us to let us know that they're not meeting their baselines, and then we realize that we don't have enough time to troubleshoot, unfortunately, that might happen. So just let us know if you anticipate not meeting your baselines or your contracted number of cases. Another deliverable is to submit a minimum of 2 client success stories per year, and that can be done through Salesforce. And if you need help with this, there's a story submissions training on the portal, on CHA portal, and I'll go over the CHA portal in a few. But the first story is coming up, the due date, and it's due at the end of September. And then the second one is due at the end of December. So you have some time. Some agencies submit more than 2, and that's great, but you only need 2 per year. Another deliverable, update the contractual documents when necessary through our Salesforce database. And every agency should have one person designated as a contracts person. If you are not sure who that is, or if that person has left, please reach out to me and we'll update that. And the last deliverable, submitting invoices by the 15th of every month. So this is for the finance team at each agency. But CHA coordinators, this is helpful for you to know as well. We have had trouble with this in the past year where invoices were submitted very late. And that doesn't help because then agencies don't get paid. If CHA coordinators, if you can let your finance team know that they only need to submit the invoice and they can submit the backup documentation later on, that would help us tremendously. And you can find more information on the CHA policies and procedures, page 30. And what Nikki and I have been doing is sending mid-year and end-of-the-year assessments that breaks down how each agency is doing with each deliverable. And we do that so you're able to catch up, or you know that you're on track of meeting all the deliverables, because we want everyone to meet their deliverables. But just make note of all these points of what's needed to have a successful year. Okay, so all CHA cases must be delivered by the end of the month. Why is that? Well, I'll let you know what happens on our end. So we have to inform the CSS leadership team on a monthly basis how each individual agency is doing and how the entire network is doing. And yeah, they want to know performance. When we write reports to the Department of Health at the end of each quarter, we want to sell CHA and let them know that we're doing a great job. We're helping New Yorkers all over. But if we're not noticing performance issues early on, then when it comes to the reports, it becomes an issue. So that's why we want all cases to be entered at the end of the month. And we also perform quality assurance and identify trends and issues. We perform a quality assurance to ensure that cases are being done correctly and we're capturing all the data that we need to identify these trends and issues. And again, for the stories, the first one is due at the end of the second quarter, and the second one is due at the end of the third quarter. And so far, I don't see any questions, so that's great. I hope I'm not going too fast. I'm taking a look to see if there's questions. Okay, so the stories, those 2 stories that you have to submit, how do we use that? Well, we write an annual report, annual report that we post on the website. We also publish stories in the New York Times. So some of you may know we have the New York Times Neediest Cases, and that's a fund for clients that really need help, and we've exhausted every other option. Sometimes we can post their stories there, or we post some very successful stories in the New York Times, and then also on the CSS website. And we also use it in the reports that we send to the Department of Health to show them how wonderful and how important your work is. Sorry. Okay. Thank you for the comment, letting me know about my pace. Thank you. Okay. So how do you submit a story? Well, on Salesforce, you go to your client case, and on the top, here's the red box. It should say story management. And then there's a release form where you upload the client story right there. And again, on the CHA portal, there's a story submission training that can provide you with more information, very detailed information on how to do this. And I also think the PowerPoint should be there as well, in case you want to just read the PowerPoint. So HIPAA, very important since we're collecting a lot of information, stories, demographics. I'm sure you all receive HIPAA training at your agencies, but we just need to go over this with you as well. And I think Diane is our HIPAA person for CHA. What this means for you, essentially. All handling of PHI must comply with HIPAA. You do not use or disclose client PHI other than as specified in the contract or as required by law, and use appropriate safeguards to ensure that PHI is used as detailed in the contract. For more information on this, you can find it on page 12 in the manual. But the reason we are going over this is that if there's a breach, it's a huge issue. So we need to know if there's a breach of PHI as soon as possible so we can create a plan of action. And we want to take the reasonable steps to do that. If we don't know of a breach of PHI and we find out later on, that might result in the termination of your agency's subcontract. And there have been cases like that, and we want to avoid it. So please, if there's a breach or if there is an issue, for example, let's say you take notes in your notebook, which isn't the best practice, but some people do, and you leave it in your car, you lose it, let us know, and we'll figure out a plan of action. Okay. So, service specifications form. I have to send that all to you. There have been many things to do, but essentially what this form helps me with is to let me know what changes have occurred during the program year. And that includes new staff. And I know many of you have done a great job informing me of new staff members that have joined or staff members that have left and came back. So welcome to anyone that's new to CHA. We're very excited to have you. If new staff members join, please let Nakia and I know as soon as possible, and provide us with their name and email. And the reason we need their name and email is so we can create a Salesforce account for them. They do need to watch the certifications training, or what we've been doing is having new staff watch the June intensive trainings, because it's more up to date. And once they watch all the trainings, we can provide a new Salesforce account. We also need to know if the staff member is on the budget, and if they are not, we require a budget modification. So again, new staff members join, please let us know, because if not, then I can't create a Salesforce account for them. I won't be sending them emails that are very important. And yeah, very important. So a question we receive often is whether a certain case can count as a CHA case. And some agencies have Navigator CAC contracts, and that makes things a little more complicated. So if your agency has a Navigator CAC contract, these services cannot count as CHA cases. If you are providing enrollment assistance through the NISO, it does not count. If you're referring a client to a Navigator or to the marketplace for enrollment, that does not count. If you're educating marketplace applicants on NISO options or assisting a marketplace applicant with a selection of a primary care physician or a plan selection, or appealing an eligibility determination, these do not count. And this is only for agencies, again, only for agencies that have Navigator CAC contracts. If you do not have Navigator CAC contracts, this does not apply to you. Okay, and then more information can be found on page 9 on the Policy and Procedures Manual. Now, appeals, I don't know if many of you help with appeals, but to avoid conflict of interest, because again, this has to do with the Navigator CAC contract. So agencies, it's better to start with the last point. Agencies that receive only CHA funds and are not navigators may assist clients with either service denial or enrollment appeals. Now, if you are receiving Navigator CAC funds, This is where the first three come into play. A navigator cannot assist with an enrollment appeal on a case in which he or she did the enrollment, no matter what funding is being used. Navigator can assist with the service denial appeal on a case in which he or she did the enrollment. And when a navigator has done enrollment, someone else at the navigator's agency can assist with any kind of appeal. So again, if any of these points were a bit confusing, feel free to reach out to us. If you have navigator funds at your agency and you need to do an appeal, we can go over this. Quality assurance. This is essentially what Nakia and I do a lot of. So we review a sample of cases from every agency, and we primarily do this during the reporting season, which is at the end of every quarter. So if a case needs additional attention, an alert will appeal. And it shouldn't say database, that should say Salesforce. So an alert should appear there, and you'll probably also receive an email letting you know to take a look at your case, something's missing or something needs attention. And it will look like this. Let's say my open case reviews. It should show up on your main page on Salesforce. But organizations should also have an internal database case review. And child coordinators, you should have access to a report on Salesforce that shows you how your agency is performing. And again, if you have questions about that, reach out to me and I'll let you know how to access that report. And I'll let you know how your advocates are doing, and if you're meeting all the requirements that we need to make a case complete. What makes a case complete? Before closing a case on Salesforce, you should make sure to include the following information. Client demographics. Why? We use this information in reports to let the state know the types of clients we're reaching. Very important. Should be a required field now, so you can't close your case until you provide client demographics. This includes race, ethnicity, age, language at home, location, and that just lets us know who we are serving and if we're reaching all New Yorkers. We need health plan information, of course, to know which health plans might be causing the most issues or cost of care issues, access to care, case savings. This lets us know how much we're saving consumers on a yearly basis, and the case savings guide should be on the portal. Needs. Every quarter, we see a number of cases that have zero needs. And that doesn't really make sense because I'm sure you're like, when you're assisting clients, you're at least helping them understand health insurance. So that's one need that usually should be on every case. But we're hoping that each case has at least one need or more. And just try your best to have at least one or more case needs. Services, you need to include services before closing case, and sentinel trends if applicable. So again, if a case has zero needs or zero case savings, and we usually see that for some cost of care cases, and we flag that because that shouldn't be the case, we will reach out to you to QA and ask you, we'll open those cases again and tell you, hey, you need to add the needs or case savings. And that is a very time-consuming process, and we really want to avoid doing that. So please, 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 try your best to add one or more needs and case savings if the case has some case savings. Okay, So specific roles, and we're almost done with my portion. How do we input case savings? That is a great question. I will send, that will be on the Salesforce training. And I will send that. Thank you for the question. Sorry, let me just take a look real quick. So to input case savings, that will be on the Salesforce recording that I'm going to send. I think Nakia or Carolina, who used to be on the CHA team, they provide a nice example showing you how to do it step by step. So I'll provide that. Next question, if we provide only information to the consumer, are we supposed to list understanding health insurance need twice? So if you only provide information, no, you only list that once. So yeah, if you only provide information, you just put one need. We just don't want 0 needs. We want to see at least one need in each case. Yes. So for navigators, because I see a question regarding navigators are not allowed under any circumstances to help a client in their appeal hearing. I will check on that. Thank you for bringing that to my attention. So I will provide up-to-date information on the navigators situation after this training, once I find out more information. Thank you. Okay. So CHA coordinators. What are our expectations for CHA coordinators? This can be found on the manual on page 13. The CHA coordinators, we expect them to attend the intensive trainings in all CHA meetings and trainings, yes. And ensure that all information provided at meetings is conveyed to the relevant staff at the organization. When we reach out via email or with policy changes, we expect timely communication. Expect the CHA coordinator to oversee the CHA services at their agency to ensure high quality. So conducting internal reviews of the services provided by their staff. Collect and report data as directed by CSS and ensure that the data is provided to us at the end of every month. Let us know if new staff join the team or if staff leave. We need to know if staff leave so we can close their Salesforce account and transfer their open cases to someone else. And then when site visits occur again, CHA coordinators take part in that as well. CHA advocates, what are their roles? You can find more information on their role on page 14. So, of course, CHA advocates attend the CHA intensive trainings. New staff should attend all the intensive training. Attend all CHA meetings and trainings, the monthly meetings. Input one-on-one case information into Salesforce. Respond to CHA communication and policy changes in a timely fashion. Site visits, whenever that will happen. And also reach out to CSS staff or the specialists for assistance. So technical assistance. So when you're reaching out for case assistance, it's incredibly helpful to include this information. Because I just want to remind you all that it's just Nakia and I, usually, that we receive, if you're reaching out to CSS, we're the ones that receive these emails, and there's 30 agencies and just 2 of us. And we love providing technical assistance, of course, but we're also doing budget stuff. We're helping with Salesforce. We're wearing multiple hats, as many of you are as well. So to make it easier for us to get you an answer as quickly as possible, please provide your client's age, the location. And when I mean location, I mean where they live and where the service occurred. So for example, the client might be a New Yorker. However, they had to go to the emergency room in Connecticut. Very important information for us to know. What is their health plan information, case details, what dates, the bill amounts, if there were any bills, were there any health plan changes, who's the provider or what hospital did they receive the service, and then what has been done so far. What have you attempted to do and what has not worked? So please provide as much information as possible in one email. And while sometimes it is helpful to see email threads or client documents, please don't send that right away, because we have received emails where we get an email thread forwarded to us, and then I don't know what the question is, or I don't know what I'm looking at. Send us an email first with all the information first, and then let us know I do have more information via client documents. Please let us know if you need that. That is incredibly helpful. So if you have any questions on this, let me know. But this is essentially what we're looking for when we want to provide technical assistance. So access to the portal. For those that have not seen the portal yet, there have been a couple of changes and we're still working on it because there's a lot of information on there. But essentially on the portal, what you will find are PowerPoint presentations and recordings of our monthly meetings. You will also find this year's June intensive recordings on there, as well as the PowerPoints. There are also case handling resources and trainings, letter templates, if you need to reach a health plan or DFS, or there's a lot of resources on there. So to access the portal, you go to this link right here, or you can go on the communityhealthadvocates.org website, and it's at the bottom, all the way, you scroll all the way down. And here is the login information. That should be correct. I should have double checked, but I think this is correct. Let me know if you encounter any issues with this. Okay. So lastly, in the manual, there are many resources there. You have the monthly meeting calendar, and that describes the monthly meeting requirements and the trainings that will happen for the upcoming year. You see the technical assistance and referral protocols and contact sheet. So you'll find how to reach the child specialist and how to reach CSS, as well as information like emails and phone numbers of CSS staff, the service parameter agreements. For the maps and program materials, if you check on the child website, it should be there, but also you can feel free to email me if you need these materials to give out to your clients, or if you want to post it on your website. And then also in the appendices, you'll find a lot of information like finance information. If you need HIPAA authorization forms, it's also in the policy and procedures manual. So just take a look. What I usually do, because of course, who can remember all this information? I just do control find, type in the word that I'm looking for, and I find it in the policy and procedures. If you're looking for due dates, this is where you find it. So I think that should be all for my portion of the presentation. I'm just checking to see if there's any questions, and yes, I will remember to clarify the navigator information. Any questions? I'll give everyone some time. Let me. Diane, did you have a question? Oh, Nicole. Thank you, Nicole. So for those that serve small businesses, we will provide a separate training after the June intensive that's specific to you all. And I think there are only two or three agencies that provide services to small businesses. I will reach out to you separately. But yes, you will have one training after the June intensive. Okay. Any other questions? Or Diane, I saw your hand raised. And sorry that I didn't catch that before.
That's okay. Hi, everyone. I just had a couple of clarifications about some questions for the navigators. The question about navigators helping with NISO appeal hearings. As you know, helping a client with a NISO eligibility determination appeal it can be a CHA case, but navigators are not permitted to help clients that they enroll in health insurance appeal that enrollment decision. And there's information about that on slide 22 in this presentation. And if folks have questions about their navigator versus their CHA-HAT, I know many of our agencies are dual funded. Please let us know. We can help answer any questions about what you're allowed to do and not allowed to do for the clients that you enroll in health insurance as far as appeals go for eligibility appeals through NISO. Now, this is not adverse determinations of coverage or benefits through their health plan, but just the appeals regarding the eligibility process through the New York State of Health. So that was one question. That's slide 22. And then just on the HIPAA slide, every year we have two trainings that CSS does for all of their network agencies. One is HIPAA, and the other is a training on submitting budgets and invoicing and how to, get paid as fast as possible in terms of our finance department and our contract with the State Department of Health. Last year, we did our HIPAA training a little bit early, and usually we do these in the mid to late summer. But last year, because we started to work from home due to the governor's executive order and the public health emergency, we did our HIPAA training in the spring, I think in April or May of last year, because we thought it would be useful for folks to have, talk about best practices in terms of work strictly from home and HIPAA protections. But this year we'll do it again in the mid to late summer, probably in August, since there isn't a regular substantive CHA training. We will have training for all the CBOs on those kind of admin pieces, probably in August, and they'll be recorded so that we can share them out if the date is not convenient live. And I think that's it.
Thanks, Diane. So yes, thank you, everyone. This is my portion. I'm going to pass it over to Diane, but if any questions come up when you're reading through the CHA policy and procedures, feel free to reach out to me. So Diane, I'll pass it over to you. And the time check, it's 10:52, so we have around 40 minutes.
Okay, I'm going to try to move away from my dog.
And I'll keep track of your questions while Diane presents.
Sorry about that, everyone. I just wanted to move away from the dog so that everyone can hear me. I have a bunch of at-home learners today and the dog, so please excuse all the noise. I apologize in advance. I'm going to try to go slow, and if if there's noise in the background or if you can't hear me, please do let me know so that I can try to make sure I'm heard, because I'm sure if you're having trouble hearing me, everyone is. Thank you so much, Catherine, for helping with this presentation. I'm going to talk about, this is for new advocates, so I'm going to give a real overview of the healthcare system and the kind of the system in which we are going to be helping health insurance consumers. And like I said, there's some pieces that are pretty specific, but this is a broad overview. You'll also get training that's much more specific on each piece of the healthcare system that you'll be working in, each kind of health insurance, including public health insurance, private health insurance, commercial, and there's a whole wealth of information, as Catherine said, on the portal that discusses different kinds of cases. We have the CHA certification, which goes in depth on each kind of health insurance, and you'll hear, if you're a new advocate, you'll hear more from Catherine and Nakia in the next couple of weeks, in the coming weeks, about what specific trainings you should view and how to send us requests for technical assistance on questions. So what I'm going to start with is an overview of the health insurance system, the ACA, the New York State of Health Marketplace. I'm going to talk a bit about some key terminology. It's important to know what kind of health insurance a consumer has when they come to you, who is the regulator, whether or not your plan is regulated by the state of New York or the federal government, and then what kind of product, health insurance product they have, because those two things determine the rules that the consumer must follow, and of course, the protections that they're entitled to under the law. So the ACA was signed into law in 2010. It's survived a lot of years now. There's a bunch of key things that the ACA has accomplished, and they still hold true in New York State. One of them is Medicaid expansion. Of course, New York is a Medicaid expansion state. A lot more people were able to get and are still able to get Medicaid under the ACA because the federal poverty level and the populations that Medicaid was available to was expanded under the ACA. The ACA also got us the Essential Plan, which is for folks who are above the Medicaid limit, and it's a low-income program for low-income New Yorkers, which is now free starting June 1st. It accomplished the New York State of Health, our insurance marketplace. Many of you are navigators that enroll through the marketplace, and it was established under the ACA. It reduced commercial premiums in New York State. Of course, the individual mandate is not applicable now, but it helped more people get on commercial insurance through the New York State of Health, which caused premiums to go down because the pool of people that were paying into the system was larger. So it really helped reduce the cost of individual health insurance through the individual market in New York State, and that has continued through to today. All right, so what does the ACA offer? Security. Insurers can't deny coverage for due to pre-existing conditions, age, or gender. Plans must offer 10 essential health benefits, which I'll talk about what those are. They must cover certain preventative services free of cost sharing. And young adults can stay on their parents' coverage up to age 26, according to the ACA. And then in New York State, we have an expansion that goes even more to age 29. The ACA offers financial stability. There are out-of-pocket There are limits on out-of-pocket expenses you must pay, and insurers must be approved for their proposed premium increases. And then it also offers control. You select a plan that meets your needs and that you can manage your account through the marketplace, and you select what you can afford, hopefully. So what does the ACA offer? As I spoke about, 10 essential health benefits are mandatory for health plans under the Affordable Care Act. That includes preventative and wellness services, prescription drugs, emergency care, mental health services, hospitalization, maternity and newborn care, pediatric care, lab services, ambulatory patient services, rehab, and habilitative services. And in terms of the ACA's future, we know that one of former President Trump's campaign promises was to repeal and replace the ACA. Those efforts so far have failed, except for the penalty for not having insurance, which was suspended in 2019. But tax credits are still in effect, and though cost sharing reductions are not. We have essential plan in New York State, so we didn't have a large population that was really affected by this change. And of course, our marketplace is still operating, and we still have Medicaid expansion. And this slide is on how people get insurance. In our country, almost 68% of folks are enrolled in private health insurance, and 37% of all the insured, 68% are in private health insurance, and about 37% are in government health insurance programs, including Medicaid, Medicare, and military programs like the VA. And then where some New Yorkers get health insurance in New York State, this is a little snapshot of our New York State of Health marketplace, where individuals and families can get health insurance, including Medicaid, Child Health Plus, Essential Plan, or qualified health plans with or without financial assistance for qualified health plans. We know under the American Rescue Plan, more folks are eligible for increased tax credits, and folks who may not have been eligible before are eligible over 400% of poverty. So always a potential resource for a consumer who's uninsured coming to you asking for help, or a consumer who pays very high costs. They may get a better deal if they're eligible to purchase through the marketplace. And I just talked about this. These are the different insurance options available through the marketplace. And one thing that I didn't say was, of course, the shop, the small business marketplace through the New York State of Health, where small businesses can purchase health insurance for their employees. And one thing that I didn't say before, but that was on that slide, that's an extremely important piece, and one that you're likely to get many questions about, is Medicare in the marketplace. You cannot enroll on Medicare in the marketplace, and there are lots of potential consumer issues around Medicare transitions in the marketplace. So folks aging into Medicare or disabling into Medicare, and being on and off the marketplace. So those questions, answering those questions are certainly a chalk case. And the Medicare Rights Center this week will talk about those transitions in another training. Okay, so when can you get health insurance in New York if you're uninsured, and through the marketplace at any time for Medicaid, Child Health Plus, or Essential Plan? There's no specific open enrollment parameters. for those public programs through the New York State of Health, or if you're getting Medicaid through the local district, but only during open enrollment if you're enrolling in qualified health plans. And that's true if you're purchasing through the New York State of Health marketplace, or if you're purchasing through an off-market plan directly through a health plan itself. Open enrollment is normally November through December, but there has been continuous open enrollment through the public health emergency for the last year and several months. Okay, so this slide talks a little bit more about some specifics in regards to health insurance programs in New York State. And I know in the beginning of the presentation, I said it was really important to note where a consumer's insurance was coming from. Who was the regulator? Was the plan regulated by the federal government, or was it a New York regulated plan? And that was important because it sets the rules that the enrollee, the client, and also that the plan has to abide by in terms of the enrollee's rights. For Medicaid and Child Health Plus, it's paid for, those programs are paid for by the state and federal governments, and they're all HMOs, or health maintenance organizations, which means that the consumer has there's all sorts of rules around the consumer accessing benefits, and also all sorts of rights and responsibilities that they get. For Essential Plan, SANE, it's subsidized by state and federal government. Those plans are offered through health maintenance organizations or exclusive provider organizations, and I'll talk about the rules for these different types of plans, which are going to be super important in terms of consumer access to care. And then Medicare, it's paid for by the federal government. It's offered through fee-for-service or managed care plans, and we will have the Medicare Rights Center presenting on Wednesday with Medicare basics, and then during the afternoon some harder topics on Medicare, like transitions. And then commercial insurance in New York, it's offered by employers or purchased directly by consumers, and it can be regulated by New York State or the federal government, depending upon where the consumer gets the insurance, what kind of employer. And they can be health maintenance organizations, points of service plans, exclusive provider organizations, or PPOs, which offer out-of-network coverage. And I'll talk about each of those models to accessing care.
Diane?
Yes.
One question came in, just a clarifying question.
Sure.
About cost sharing reductions and whether they are in effect or not. So the person's asking just to make sure, are they not in effect?
I believe that, so there's a bunch of back and forth about the federal government paying for them. So I think that the federal government took back or held back the money to pay for them. Through New York State of Health, consumers might still be enrolled in plans where the cost to them is lower under cost sharing reductions, but the feds don't pay for it. So that's why that slide was there. I can confirm with our Navigator program manager, but I believe that slide is just about who pays for them.
Great, thanks.
So the feds no longer do. Okay, so this is a case example about getting coverage, since I just talked so much about the New York State of Health. Andy's 35. He makes $100,000 a year. He's self-employed and too busy to enroll during the open enrollment period. He calls to find out his options. He was thinking of going straight to a health plan to buy insurance, but he was told he needed a special enrollment period to enroll. Can he get coverage straight through the health plan if he doesn't have a special enrollment period, and what are his options? So for Andy, he has to have a special enrollment period to enroll. Those rules are the same if he's enrolling through the New York State of Health or directly through a plan outside off market. As we know, open enrollment has been extended through the public health emergency. So in this example, he would be able to get in right now. And it seems like we're just going to have a nearly 2-year open enrollment period. Okay, so I'm going to talk a little bit about some definitions or key terms. Since this is geared towards new advocates, it's a little bit simplistic, but I'll try not to belabor it too much. As we know, the marketplaces were created by the ACA, and a lot of them are funded by the ACA. It's where people can shop directly to get health insurance. In New York, it's called the New York State of Health. A qualified health plan is a private plan offered on the marketplace, but it must be certified by the state. It must have adequate networks and cover essential health benefits. And there's lots of different like rules and parameters that the New York State of Health gives to qualified health plans and any plans that are offering through the marketplace. And then they're offered through metal levels, QHPs are, and those metal levels are bronze, silver, gold, and platinum. And for the higher tier plans, there's a higher monthly premium, but lower out-of-pocket costs when services are received. So the more you pay each month, the less you're likely to pay when you go see a doctor, and vice versa. For a bronze plan, for example, you're going to pay less each month, but have higher cost sharing when you go to get a service. And then I talked a little bit about tax credits and cost sharing reductions. They're financial help in order to help pay for insurance. And the reason why they're called APTCs is because you can take them in advance when you're enrolling, and many people do. I don't know of any examples where people said, I don't want the tax credits now, let me get them, at refund time. But those advanced premium tax credits help you pay for insurance and help with other out-of-pocket expenses, like they reduce deductibles and co-pays for cost-sharing reductions. So when you enroll through the New York State of Health, you put in information about what you expect to make for the coming year for eligibility for premium tax credits, and then you get premium tax credits on a sliding fee scale based on that, and that goes towards your premium. So what they spit out is what your premium would be after those tax credits are applied. And then I spoke a little bit about this special enrollment periods. That's when you can enroll in the New York State of Health, and this term is also used for commercial insurance through employers. It's a specific time when you're allowed to enroll in health insurance. So there's an open enrollment period through the marketplace that's normally November, right at the end of the year, November and December. And January, and employer-sponsored insurance sometimes has other open enrollment periods. It could be around the same time of year. Sometimes it's in April. Sometimes it's in the summer. So the special enrollment periods are when you have a situation outside of that open enrollment where everybody's enrolling or changing coverage, where you'd be able to enroll or change coverage. And those include marriage, having a baby, changing your immigration status, moving out of state, losing coverage, and I'll talk a little bit in more detail about those special enrollment periods. Okay, so I use these terms a lot. About time I defined them. Premiums. A premium is what an enrollee must pay for health insurance on a monthly basis, an ongoing basis. If you don't pay on a monthly basis, your coverage will end. And when you're enrolled in employer-sponsored or union-sponsored coverage, for example, normally your premium or the portion of the health insurance that you're responsible for comes out of your paycheck each month. For enrollment through the New York State of Health or purchasing on the off market directly with the plan, you have to pay each month in order for your coverage to be active. Cost sharing are the out-of-pocket expenses you incur when you use a health service. So an example is, $50 copay every time you go to a specialist. $100 copay if you use the urgent care. A deductible is the amount an insured person must pay before the plan pays for the cost of medical services. So this is sometimes hard for consumers to wrap their heads around, but I like to explain it in terms of a car insurance deductible, which many people are a little bit more familiar with, where if you get into a car accident and you have a certain amount of damage, your car insurer will only pay over that deductible amount for that damage. So if you have a car accident that causes $5,000 worth of damage to your car and your deductible is $2,500, your insurer is only going to pay over the $2,500 when you get your car fixed. And then I talked about a copay, a fixed amount for each service, and co-insurance is a person's share of the cost of a covered health service and it's usually a percentage. So in Medicare, it's 20%, for example, that original Medicare that a beneficiary is responsible for, and Medicare pays the 80%. And a few more definitions. Employer-sponsored insurance, of course, is insurance provided by an employer to their employees and the employees' dependents. COBRA is the continuation of coverage that an individual can get when they leave employment. There's a 60-day period to elect from COBRA from the day of the notice that you get regarding election. You have to pay up to the full amount of the cost of insurance if you are eligible for COBRA upon separation from your employer. So if they paid anything and you paid a piece, they no longer pay that piece. And there can also be administrative fees associated with that. So COBRA can be quite expensive. And you're eligible for COBRA for 18 months or 36 months, depending upon the type of qualifying event you have, being separated from employment due to employment termination or disability, for example. And under the American Rescue Plan, there are some pretty steep COBRA subsidies that people are now eligible for, so that the cost of COBRA can be much lower for them. And then some other key terms, fee for service. Well, we discussed this a bit when we talk about Medicaid and fee for service Medicaid. Fee for service is when doctors and other healthcare providers are paid a predetermined fee for each service that's performed. So you may not receive your care through a health plan, but the State Department of Health, for example, in the Medicaid program, may agree to pay a specific fee for each service you get if you're not enrolled in a Medicaid managed care plan. And then managed care plans are where plans receive a monthly payment to cover all the healthcare costs of the enrollee, and then the plans figure out how providers are going to be paid directly based on contracted rates. And many, if not all, types of insurance offered through New York State. So all the public health insurance programs, including Medicaid managed care, Essential Plan, Child Health Plus, qualified health plans, are all offered through managed care products. And that's with the exception of folks who are in fee-for-service Medicaid. almost everyone who has Medicaid has to enroll in Medicaid managed care, except for certain folks. A very few, a very short list now, including Medicare beneficiaries without long-term care services, people on emergency Medicaid, people with other comprehensive primary insurance. So almost everyone has to enroll in these plans that has many different rules. Okay, so I talked a little bit about this in the beginning, and this is a pretty important term for folks who might get commercial insurance consumers or employer-sponsored insurance consumers come to them. And this is the difference between a self-funded plan and a fully insured plan. Self-funded plans are federally regulated plans where the employer pools a bunch of money in order to pay an administrator to administer their health plan. The employer assumes the risk of the insured getting sick and paying for their costs, and they're federally regulated, and the employer basically pays for the claims. For fully insured plans, they are state regulated. The employer pays monthly fees to an insurance carrier. They don't assume the risk. The insurance company itself assumes the risk for claims by the enrollees. And of course, the plan must comply with state regulations. So the rules for the different kinds of plans are different. Of course, fully insured plans that are New York regulated, the consumers have broader protections. And we'll learn a little bit more about that. Okay, so this is often difficult to determine whether or not a client's or a consumer's plan is fully or self-insured. It's important to know, just to know what their rights are. It helps to know how many employees the employer has, where they operate, and whether or not they're a union. If the employer that offers the insurance is in multiple states, like for example Verizon, they are likely a self-insured company, and therefore are regulated by the federal government. Normally, union-sponsored plans are also self-insured. So these rules are really important, especially in terms of the handling of appeals and kind of administrative processes, which are very different for fully or self-insured consumers. And then this is just information about the regulator for different kinds of commercial insurance, either self or fully insured. Basically, this is who to complain to. Our Department of Financial Services, or the Attorney General's office in New York State, and EBSA, the Department of Labor, for self-insured plans. Okay, so now we're going to talk a little bit about the different types of managed care plans that a consumer who comes to you for help might have. And the reason why this is important is because what kind of plan the consumer has is really a roadmap as to the rules of the plan. And oftentimes a client will come to you and say, well, my plan is not paying for a certain service, and you can ask a few questions to figure out whether or not the consumer did what they were supposed to do in terms of the plan's access rules to know what went wrong. So how a plan manages care depends on the type of plan they have. And these managed care plans do just that. They manage the care a consumer has, and therefore have a lot of access rules that consumers need to follow to get care, but they also have some good consumer protections in New York State. Next slide, please. Thank you. So health maintenance organizations, many plans offered through Public health insurance in New York State are health maintenance organizations, including Child Health Plus plans, Medicaid managed care plans, some QHPs, and some essential plans offered through the New York State of Health. HMOs limit care to in-network doctors that contract with the HMOs. So they almost never cover out-of-network services unless you get prior authorization, so permission from your plan to go to an out-of-network doctor before going, or unless you have an emergency. You must select a primary care physician, and he acts as the gatekeeper to your care, which means that the primary care physician would do a lot of the prior authorization or referrals to specialists. And in an HMO, you need a referral from that primary care doctor in order to see a specialist. So they really act as the gatekeeper. You kind of can't get any other services in the plan without going through that PCP. Typically, HMOs have lower premiums than other type of plans. And as I said before, in New York, all Medicaid managed care and CHIP plans are HMOs. Child Health Plus plans are HMOs. EPOs are very, very similar to HMOs in that you must only use in-network providers. There's no out-of-network benefits, again, with the exception of going to an out-of-network emergency room or getting prior authorization to use an out-of-network provider because of limits to the network. But you do not have to select a PCP, and you are not required to get a referral to see a specialist. So a little bit more freedom in this plan, and they usually cost a little bit more for that reason. And then a preferred provider organization, members can go out of network for any reason. There is a network of providers where the plan will pay for most of your costs for an enrollee, but you are able to see out-of-network doctors, and plans pay what's called the allowed amount to out-of-network providers. That's usually between 70 and 80 of the out-of-network costs. So they do not pay the full amount of out-of-network providers, even though you're allowed to go to an out-of-network provider for any reason without getting a referral, without getting prior authorization. So the plans pay a specific amount, and then your cost sharing, your co-insurance is the rest of the 20 to 30% of the out-of-network rate, which is called co-insurance, and it's the client's responsibility. I think one thing that we see a lot on our helpline is folks who have PPOs and go out of network but don't realize what a low rate they're going to get reimbursed for out of network providers. So sometimes, in PPOs having that freedom to go out of network is great, and so they cost more, but you also have a lot higher out-of-pocket expenses. The consumer will have a lot higher out-of-pocket expenses. So a CHA case, of course, is helping consumers negotiate those out-of-pocket costs. And we see that a lot on our helpline. And point of service plans, they're a combination of HMO and PPO plans. You must choose a PCP, but you do not need a referral to see specialists. You can go out of network, but in doing so, you'll have to pay more of the cost yourself, similar to a PPO plan. An exception is when a PCP refers you to a specific out-of-network doctor, in which case the plan you only pay your regular in-network cost sharing. So lots of rules in all these different kinds of plans, and where we see this as a CHA case is where consumers don't understand the rules or don't do it quite, don't comply with the rule quite as well as the plan would like them to. Okay, so here's a case example. Joanna recently enrolled in a plan through the marketplace. She received a letter from the plan informing her that she has not chosen a PCP, and she should do so right away. Otherwise, one will be assigned to her within 30 days. What type of plan is this? What happens if she's not happy with the doctor selected? or the one she's auto-assigned to. So lots of plans have this rule, especially HMOs and Medicaid managed care. This is a rule. If you must choose a PCP or one will be chosen for you. And you can switch PCPs if one is auto-assigned to you and you don't want that PCP, but just a note about managed care plans.
Mom, can I tell you?
We just have one more slide.
I'm sorry, my 7-year-old really has to tell me something about online learning.
No
about
problem.
Junie B. Jones. It's super important that I know about the Junie B. Jones books. I'm sorry, guys. All right, so we're almost through here, and thank you all for your patience. Some advocacy tips, and I talked a bit about this. This is such a super important piece. A lot of times I give feedback on the helpline where, you know, the answer to these questions would be able to kind of solve the case very quickly. So in most cases, you'll need to determine what type of insurance the client has: Medicare, Medicaid, Child Health Plus, Essential Plan, commercial insurance through an employer, commercial insurance privately purchased or through the marketplace, union-sponsored insurance. Because depending upon what kind of insurance you have, it determines the rules you have to follow. And then what type of plan you have. All of these different plans have very specific access rules, and often your CHA case will be about the consumer not complying with those access rules or the plan not properly informing them. And then, is it self or fully insured? What laws apply to these different plans, and who do you go to complain? Who's the regulator? And then also determine who manages and oversees the program so that you can complain. In Medicaid and EP in New York, it's the Department of Health. For Child Health Plus, fully insured commercial plans and QHPs, so employer-sponsored and QHP plans, it's the Department of Financial Services. This is our Department of Insurance in New York State. The Department of Labor, that's for self-insured plans, and the Center for Medicare and Medicaid Services for Medicare plans. And one other question that's super important in terms of intake and understanding a client's options is, what's their income? Often, and the income of in their household, of any legally responsible relatives they have, because often, you know, if you can't get an insurer to hold them harmless or pay or remedy their denial or overturn their bill, you're talking about hospital financial assistance or other kind of financial assistance or debt negotiation. So super important to know what the consumer's financial situation is, even though at first blush it may look like their financial situation really has nothing to do with the denial. It's something that is a very important piece to know. Okay, so that was a whole lot of information. We're a minute or two over. I have one follow-up to confirm, which is in regards to CSRs and payment for CSRs. Are there any other questions? I know that was such a mouthful in such a short period, and it's really meant to just give a very brief overview and snapshot of the systems we're working in and our consumers will be working in, and then you'll get more in-depth training about each kind of program this week and through the certification, the CHA Advocate certification.
Yes, thank you so much, Diane.
Should I take some questions if there are any? Catherine, do we have time for that?
Yeah, I mean, looking to see if there's any questions. I know other than the cost sharing reductions, I'll also send an email regarding the navigator, just to clarify the navigator stuff. We will stay on to take any questions if there are any, but if you don't have any questions, thank you so much for joining us. We hope this was helpful, and we'll see you at 2 p.m. for our how to handle prescription cases training. But we'll stay on for 5 more minutes in case there are any questions. Thank you all.
Thank you all. Thank you all for your patience. Welcome to the new CHA contract year and to CHA if you're a brand new advocate. And apologies again for all the noise in the background here.
Thank you. Okay, Diane, so I don't see any questions, so I'm just gonna close off.
Okay, I just want to say for anybody who's still on that CSRs are still in effect. It's just the difference was who pays for them, the
Oh.
feds or the state, like the consumers are held harmless for them, so they're still in effect for consumers, but there had been a debate and now probably won't be again about who's paying for them, the state or the feds. And
Great,
the feds had not paid for them for a long time and then said they would no longer pay for them, but they're still in effect.
great. I'll send everyone an email so they know. Thank you.
Thank you, Catherine. Bye now.